problems by yourself. So today's topic is on issues in dietary assessment. So there are actually two main issues in dietary assessment. The first one is we will eventually find measurement errors in dietary measurement, and also regarding validity and reproducibility of dietary assessment. Okay. So these are the types of errors, measurement errors in dietary assessment. So we have respondent or interviewer biases. And then we have respondent memory lapses. We also have incorrect estimation of portion size, flat slope syndrome, omission of information, both by interviewer and also the respondent. And finally, coding and computing errors. So these are the types of errors that you find in dietary assessment, which we call it as measurement errors. So let's look at one by one of the measurement errors. The first one is respondent and interviewer biases. So we have two parties here, the respondent and also the interviewer. Okay. So for the respondent side, the bias may be caused by incorrect questions, incorrect recording of response, especially when they have to respond on their own self-administered questionnaires. So there are also some biases because of there's intentional omission. They don't want to report certain types of foods or beverages. Biases associated with interview setting, whether the interview is done at home or at the clinic, at the office. So it might contribute to some bias. Distraction, okay. Confidentiality and anonymity of respondents, so they are not sure whether their responses are confidential enough or is protected by us, so they might be responding differently. And finally, degree of rapport between interviewer and respondent. Okay, so these are from biases from the respondents. From the interviewer side, so there will be biases caused by different interviewers who probe information to varying degrees. So there are some interviewers who like to probe a lot of questions to the respondent, therefore they will get more information, while some might think that it's not important to ask certain questions, so they will get less information. And then intentionally omit certain questions, so maybe they are in hurry, or they assume that the respondents is not consuming that type of food, so they intentionally omit certain questions. And finally, record response correctly. Okay, so there will be some errors when they record the responses from the respondents. So to assess from both respondent and interviewer, so we should compare intake calculated from multiple interviews on the same subject during the same 24-hour eating period using different trained interviewers. So this is just to assess bias. So you might have two interviewers in a project, so you compare the quality of interview but perform on the same subject in the same period of time. Okay, so you might see some differences, or if the interviewer is not prone to any biases, so you see similar responses in the questionnaire. So over-reported good foods like vegetables and also fruits are usually done by underweight person, and underreporting of bad foods, example like snacks, use of tobacco and alcohol by overweight person. So underweight person might tend to over-report things, foods, and overweight person might tend to underreport some of the foods. So to minimize this bias, interviewers should be trained to anticipate and recognize potential source of distortion and biases. So it means that the dietary should be done by a trained interviewer, not some random people who just get some 5-minute briefing and then they cannot do a dietary assessment on their own. So they should be properly trained to minimize all these biases. Okay. So the second measurement error is from the respondents' memory lapses. So this may result in unintentional omission or addition of foods in recall memory. So this is unintentional because of their memory. This can be reduced by probing questions and by using memory aids. Okay, so we have to check on recall ability, obtain duplicate recalls collected by independently by 2 trained interviewers for the same 24-hour period. So this is similar to the previous one, how you want to detect the biases. And also foods contributing to the main part of the meal remembered better than the condiments. So we usually remember the main meals like white rice, and then what are our protein, and then we forgot about the sauces, the kuah, the gravies, and tidbits and so on. So respondent memory lapses is not only for elderly but also for all age range. So we must anticipate this from the respondents. The third one is incorrect estimation of portion size. So this is the largest source of measurement errors. In fact, if you see even the National Food Survey, Malaysian Adult Nutrition Survey, we can't believe that Malaysians are consuming 1,600 calories, and yet half of the population is having overweight and obese problem. So it's just not right, because the main reason might be because of incorrect estimation of portion sizes during the interview itself. So occurs when respondents fail to quantify accurately the amount of food consumed, or because of how the interviewer asks questions. Maybe when they ask questions, they just say 1 plate, 1 tablespoon without showing any food models or pictures. So this will also contribute to respondents' error in estimating portion size. So to minimize errors, we must use food models like here, and also photographs. So this is the photographs, 4 series photographs of French fries from the smallest size to the largest size. I think they have more pictures. Usually it comes in 3 series or 7 series of pictures. So if you have seen our food atlas, Malaysian food atlas by Prof. Susanna and her team, they only give one type of serving size, right? Have you ever seen the food atlas? Anybody?
Yes, I've seen before.
Yes, they only have one picture for each food, right?
Yeah,
So
only one.
only one. So it might be helpful if they have several a series of pictures, so that the respondent can choose which is their serving size. If you only have one, so if they are consuming a smaller size, they cannot show it directly on that picture. They might estimate saying that it's half of this, uh, half 1/3 of this, and so on. So these are the food models. Um, and then this is an example of photographs of 1, 2, 3, 4, 5, 6, 7. This is 8 series photographs. Yeah? It's a red bin. Obviously, it's from overseas and not Malaysian. So people can, the respondents can easily select which serving size that they actually consume. Okay. So they also have some option that I had less here, less than this, the 8 photographs, or they had more of that 8 photographs here in case they consume a lot more than this. Okay, so there are several methods to do this. You can use food model or also use photograph series. So the fourth one is the flat slope syndrome. This is a bias that may be introduced during recall by the tendency to overestimate low intakes and underestimate high intakes. So a person might consume a very little food, but they think that they already consume a lot. And another person might have consumed a lot, but they think it's still a very small portion size. So that is flat slope syndrome. So this is actually influenced by social desirability of the foods of the person. So it depends to how they describe their portion sizes. The fifth one is omission of information on nutrient supplement usage. So some of the nutrient supplement actually contribute a lot to the nutrient intake, but not calorie. So failure to collect data on nutrient supplement and systematic underestimate of certain intakes of certain nutrients. Examples that people might consume is vitamin C, and then you might have B complexes, calcium supplements, fish oil. Okay, so the the data involved when you want to record about nutrient supplement usage is the type of the supplement, the amount, especially the dosage, and the frequency of intake. So all these are important. Maybe if the person can't recall on the amount, you can ask regarding the brand, the color of the bottle, and so on. So we can be creative in probing question to the respondent. And the final error is, these are the main errors. There are a lot of other errors. So coding and computing errors might happen when we wanted to transfer the portion sizes reported by the respondent into household measures to gram of intake. Okay, so this happens when we incorrectly code the foods in our record. So the computerized nutrient database has its own limitations, such as not all nutrients or foods covered is in the database. Therefore, it provides inaccurate data. So those who have tried to enter your 24-hour diary record or weight food record might have seen some of the problems with when you see my FCD. So you might have consumed mee tarik, and there is no mee tarik in the food composition database, my FCD. So what you have to do is you have to find similar food which have similar nutrient composition and ingredient to substitute that food into the database. But then it will contribute to computing errors and also inaccurate data. So this slide summarizes the sources of error for 4 types of dietary assessment method. So if you can see for 24-hour diet recall, okay, before that, plus means error is likely. Negative means error is unlikely, and then you can also see there are some with plus minus sign, which means that the error is possible. So for 24-hour diet recall, error is likely for omitting foods. Okay, when we do 24-hour diet recall, there is possibility of omitting food from the respondent side, adding food from the respondent side, estimating food weight from the interviewer side, because we want to convert the household measurement into weight, Estimating frequency is not unlikely for 24-hour recall because 24-hour recall doesn't ask for frequency. Okay. Day-to-day variation. This will definitely happen in 24-hour diet recall because not all days we consume similar type of food, so there will be day variation. Changes in diet is unlikely because when we interview them, we do not announce to them that before we interview, don't tell them that tomorrow we are going to interview. So we just interview them when they come to the clinic without announcing them to them that we are going to interview. Okay, so therefore there will be no changes in diet. And there will be some coding errors in 24-hour diet recall when you enter the data into the nutrient composition database. For diet history, it's quite similar, except for there is estimating frequency error, because in diet history, we ask about frequency, but there is no day-to-day variation because the history asks about the past 7 days. And for estimated record, there is a possibility of omitting foods because the act of recording might is depend to the respondents, right? So they might omit their food from reporting in the estimated record. And then adding food is not likely in estimated record and weight food record. Estimating food weight is likely for estimated record because we have to estimate the weight, but it's not likely in weight food record because the weight is given by the weighing scale. Estimating frequency is not likely for both of these type because there is no frequency. There is day-to-day variation similar to 24-hour diet recall for both methods. Changes in diet might happen for estimated record and also for weight food record because they might don't want to select certain foods that's hard to weigh and on that day. And there is coding errors for all types of dietary assessment method. So this figure shows the track of where the behavior and interaction from the reporting until the calculating of intake, where are the errors happen. Okay, if you go through this figure from the top, behavior and interaction, message from the researcher, attitudes towards the food by the respondent, socioeconomic status by the respondents, and image management by the respondent, it will cause some errors in reporting. So how do they report the food is by either by recording, by recall, by history, or by FFQ. So if they are recording their intake, there will be altered food choice, especially when we do weight food record. If they are recalling or history, there will be memory involved. If they have poor memory, it will affect the recall and history. And if they are unable to summarize their dietary pattern, because when we do FFQ, we really have to describe our foods. So if they are unable to summarize their dietary pattern, or they have a false perception of their own diet, it will affect reporting for diet history and also food frequency questionnaire. During the identifying food stage, if there is inadequate communication or description, so it depends to the researcher's choice from food tables whether for foods that we recall or history, but it depends to the subject choice from the questionnaire for FFQ. So food tables here means our food composition table, yeah. So for those food items that we recall and history, there is we have to choose which food from the food combination table. Some of the food, like I've said before, some of the food might not be there. We have to substitute with the new food. So it depends to the researchers from the food tables. Whereas for FFQ, we have listed all the foods and it cannot be changed in the food list in the FFQ. So it's the subject choice from the questionnaire, which food they consume. Okay. In terms of the quantity quantifying step, there will be weighing error or poor estimation. So whether it's weighed or estimated, this is for record, or estimated for recall and history. So there'll be some errors here. And for FFQ, it depends to average portion, whether it's small, medium, or large. Some FFQ have options to choose small, medium, or large, but some might ask about what is the serving size that you consume. So if the person have poor quantification ability, so they'll affect the average, the selection of, or the quantifying of the food intake. Okay? In terms of frequency, there will be underreporting or overreporting of frequency. But for food record, diet recall, and diet history, it is as reported by the respondent. But for diet history, it's actually the subject estimate the frequency. Similar to FFQ, it's subject choice from the questionnaire. So if we have 5 choices of the frequency, they have to choose which of the frequency relates to them. So depends to the subject itself. And finally, in calculating the intake step, so we'll have food coding, portion weighing, and nutrient content per gram for all these 3 methods. And for FFQ, we have another additional item, which is the frequency during calculating intake. So the nutrient content for all these methods will come from the food combination tables, which might also differ from the actual composition of the food consumed by the respondent, because food combination tables is fixed, whereas actual composition might differ from household to household, depending to the recipes and so on. Okay. So before we move to in the second part of the lecture, do you have any questions? No, no questions.
No, doctor.
Okay, great. So it's quite straightforward. The second part of this lecture is on validity and reproducibility in dietary assessment. So if you have not heard about this term, reproducibility means the ability of a method to produce the same estimate on 2 or more occasions, assuming that nothing has changed in the interim. So reproducibility means that reproduce same estimate. We have the first occasion and the second occasion. So between these 2 occasions, the reproducibility should be the similar. When it's similar, we can say that the reproducibility is high. If the first occasion and the second occasion we have different estimates, means that the reproducibility is lower than it should be. For validity, we always hear about valid. So validity is the ability of an instrument to actually measure what it intended to measure. So if a weighing scale should measure the body weight of a person, so it should measure the actual body weight of the person. If a known weight is 5 kilogram, the machine should show the weight is 5 kilogram, cannot be 6 kilogram or cannot be 4 kilogram. Okay, so it should measure what is actually intended to measure. So that is briefly on reproducibility and validity. So we will go into reproducibility or reliability first. So the other name for reproducibility is reliability. Okay, so it's a method considered reproducible, precise, if it gives very similar results when used repeatedly in the same situation. Okay, so in the same situation, if you have to repeat the method, it should give the same result. It shouldn't be it doesn't matter if it is correct or not, but it should show the same result. The reproducibility of a dietary method is a function of random measurement errors, uncertainty from two variation in daily intakes, and also variability arising from confounding like age, sex, season, chronic illness, and also dieting. So if subjects consistently under or overestimate portion sizes consumed, the method may have good reproducibility but poor validity. So if every time you do a diet recall, the respondent every time they overestimate the similar portion size, it means that it has good reproducibility, but it doesn't mean that that is correct because they are overestimating their intake. Therefore, it has poor validity. Okay, so if a method with good reproducibility can also be invalid. If you can see target A here, this is poor validity but good reproducibility or reliability. So if it is good validity and good reliability, it should be as shown in target C here. Okay, so reproducibility means every time you measure, it measures at the same location, at the same value. Okay, although the value is not correct, but if it is consistent, we call it as reproducibility. But if it is at the same correct value, we call it as validity. So method with good validity cannot have poor reproducibility. So whenever you are having a good validity, by default you will have a good reliability or reproducibility at the same time. You cannot have good validity but poor reproducibility. Okay. So how do we assess reproducibility? So we assess them using test-retest design. So the name test-retest means you test the first time and then you repeat the test again. So we call it as retest. So we apply the same dietary method to the same subject after a pre-selected time interval. So there will be some time interval. The time interval chosen depends on the time frame of the method. Normally 4 to 8 weeks are recommended to minimize changes over time. So 8 weeks is the maximum life. 8 weeks is around 2 months. 4 weeks is 1 month. So this is recommended to minimize changes over time and recall of previous and to avoid seasonal changes in food habits. So we do not want the time to be very short because they can recall what they have just answered. Okay, so we need some time interval here. So 4 weeks to 8 weeks is recommended. We do not want it to be very long because there will be some seasonal changes in food habits. The season might change, the availability of the food might change, okay, if it's very long. So 2 months is the maximum to do a test-retest reproducibility. If several interviewers were used in a project, then between interviewer reproducibility should also be assessed. So if you have several interviewers in the project, So you can ask the person to interview subject A and another interviewer to come and assess subject A again. Then you can do interviewer reproducibility. So you must take note that in test-retest design, the representative sample of target population must always be used. So you cannot just conveniently select whoever around to be your subjects. The sample must be representative of the target population when you do a test-retest design. So these are the many factors that affects reproducibility. So you have sample characteristics, nutrient of interest, technique used to measure intake, time interval between test-retest. So we have just said just now 4 to 8 weeks is the best. Between and within subject variation. So between subject variation or within subject variation. Between means between subject A and subject B and subject C. Okay, that's between subject. Within subject variation means on subject A itself, day-to-day variation maybe. Okay, so that is within subject variation. And then you have seasonal effects, and finally is the sequence or training effect when you do a reproducibility test. So the first one is sample characteristics. So in terms of age, for young children or even us adults have erratic diet. So we tend to change our diet frequently depending on the availability of foods at home or around us. So we have different meal time on different days. We choose different foods. Okay. But then for elderly, they always are more stable in terms of their diet, okay, because they only eat certain types of food. Sample characteristic also depends on the socioeconomic status, low and high income countries. So the degree of dietary diversity might be different. For low socioeconomic, low income countries, you will have a lower degree of dietary diversity. Means that you have only limited types of food to be consumed. In high income countries, you have a more variety of food, so the degree of dietary diversity is higher. Sex might be different due to amount of food consumed, but not the pattern of the food. Okay, so to correct this, we use nutrient densities so that the differences between sex might disappear and between subject variation will be reduced. So nutrient densities means like we know that female usually consume lower calories compared to male. So example of nutrient density is for 2000 calorie, a male might consume 30 grams of fiber. But then female only consume 1500, and then they might consume 25 gram of dietary fiber. So when we do nutrient densities, we divide, we try to correct and report the nutrients in 1000 calorie maybe for the example of dietary fiber. Yeah? So just now for male is 30 gram dietary fiber divided by 2000 calories times 1000 calorie. And then for female, just now was 25 gram of dietary fiber divided by 100 and divided by 1500 calories times 1000 calories. So the unit of dietary fiber will be gram per 1000 calories. So then you can compare between male and female because the calorie is already similar in 1000 per 1000 calorie. The second factor is nutrients of interest. As an example here, vitamin A is the content of vitamin A is higher in few foods. So if during the reporting they did not consume that type of food, the vitamin A intake will be lower. But if during that interview session they consume that type of food which is high in vitamin A, so it might increase their vitamin A intake. So it also depend on seasonal variations because we have our fruit season, we have our monsoon, so really depend on seasonal variation. Technique used to measure food intake is also a factor affecting reproducibility. So FFQ, which sets standard reference portion sizes, have higher reproducibility, whereas FFQ and diet history, which assess usual food intake over longer time interval, might have lower reproducibility. Okay. So time interval between repeat administration is also a factor affecting reproducibility. So there is a higher correlation with shorter interval, but because when we do shorter interval, it avoids seasonal differences. So shorter means in the range of 4 to 8 weeks, as we have explained just now. So between and within subject variation, is also a factor affecting reproducibility. So by increasing the sample size, we will reduce between subject variation, and increasing number of measurement days will reduce the within subject variation. So if you have a larger sample size, so between subjects variation will be reduced. Okay, so between subject A and subject B, the variation might be reduced. Okay. And if you increase the number of days, instead of 3 days that recall, you do 7 days that recall. So by doing that, you will reduce the within subject variation. Day of the week effects. So intake of weekends and or market days often differ from weekdays. So we know that in weekend we are not working at home, and then we might go to market, buy more foods, eat outside away from home. So the intake will be different on weekends and weekdays. So this can be accounted for by representing all days of the week in the design. So to avoid days of the week effects on reproducibility, you can include all days of the week in the design. So as we are doing now, we do 2 weekdays and 1 weekend. So that is acceptable. Seasonal effects is greater for intakes of foods than nutrients. So especially when you are interested to find what are the food groups that the person have consumed. So seasonal effect will have greater effects on that type of reporting rather than nutrient reporting. Can be accounted by including random days representative of all seasons, or doing survey over a long time. So if you want to do a habitual intake, so you must collect dietary data during all seasons, so from January to December, so that the seasonal effects will be reduced. The sequence or training effects. So when you do reproducibility, you have test 1 and test 2, right? So the sequence or training effect is possible. It may be severe if subjects complete recalls or records on consecutive days. So if they just finish the first recall on Monday, and then on Tuesday you already wanted to do the second recall, there will be some training effect because they can already recall, or they already know how to report certain things in the form. It should be completed on a randomly selected days of a week, so that sequence or training effects can be reduced when doing reproducibility. So any questions so far? Is it clear, or do you want me to repeat certain parts?
Doctor,
Yeah.
for diet recall, you do on random days of the week, right? But for measuring, uh, for measuring the item, you can do like any particular or continuous day in the week, right? No problem with that. Say
Measuring
if I'll measure on Monday and then I can measure on Tuesday as well. And then another one is weekend, I think on Saturday. Is that correct?
you mean weight food record, is it?
Yes, yes.
Yes, you can do that because when you do weight food record, you usually there is no errors in terms of reporting because you have to weigh whatever you eat on that day. So it's different from recall. Uh, that recall. When you announce that you already wanted to do a 24-hour recall, the person might already have caution that to remember all the foods they wanted to report on the next day. So for weight food record, there's no problem. But for 24-hour that recall, you shouldn't do a consecutive days.
Okay, understand.
Okay.
But I think the problem with the weight record is people tend to be, they change the diet because they are lazy to, I guess,
Yeah.
I don't want to eat so many things and so on. So it will
Yes,
affect
correct.
as well.
Yes, you're correct. That's the downside of weight for record. It might change person's diet because they do not want to actually do a difficult measuring for that day. So they always choose things that's pre-packed, things which is loose, no gravies, so that is easier for them to measure. Okay.
Okay, doctor. Thank you.
Any other questions? Is it clear? Okay, so I guess there is no questions. We shall continue for validity. So we have finished for reproducibility. So validity is when investigators are interested in knowing what a respondent's usual intake is, what actually they consume. Okay, so then we do a validity test. Validating an instrument involves comparing estimates obtained by the instrument itself and comparing it with another method that can measure respondents' usual intake. So we have two types of validity. The first one is absolute validity, and the second one is relative or criterion validity. So absolute validity is only possible when the person is institutionalized or in a hospital setting. Example, when we really have to observe the diet among the patient in the residential metabolic unit. So this is where we know that that person is consuming what from the morning until the night. So we know what is the person is consuming if the person is in front of us, institutionalized in a hospital setting, so they sit in a ward. Then we can monitor them. We are not supposed to just stand beside them. We can have CCTVs and so on to monitor their eating activities. But then it's very difficult and impossible to know a person's true usual intake most of the time. So the solution is to have a relative or criterion validity where we compare a new instrument with another instrument which we call them as gold standard. Okay. um, that gold standard instrument should have a greater degree of demonstrated validity or face validity. Okay, so the question is, which instrument gives the best estimate of usual intake? So there is no one instrument that can give best estimate of usual intake. So we will see throughout the lecture how you want to increase the quality of a validity experiment that you are doing. Okay. So for measuring absolute validity, you place a person in a metabolic unit where you can see you have given them bed, there's their restroom, working table, okay, and then food will be delivered through a window here, and then they must stay in this metabolic unit for a period of time where all their activities will be monitored. Even the foods will be monitored. Whatever given and taken back, left in the plate is measured. Okay, so that is absolute validity, measuring absolute validity, so that we know what is actually the person is consuming. But we cannot do this to all our subjects. It will be costly to do experiments like this. So in absolute validity, the method is you surreptitiously observation in institution, or surreptitious weighing in institution, or videotaping single meals in metabolic units or institution. So we observe them without announcing to them that we are observing, but of course they have signed consent form to be involved in this type of studies. The results that we get from absolute validity is agreement on mean energy intake, which is often acceptable. Agreement for energy intake from snacks is often poor. Sometimes we miss the things that they consume on their own time whenever we are not observing them. Agreement for intakes of foods and nutrients often inconsistent. Okay, so therefore we suggest to use biomarkers for absolute validity, where we have to choose the biomarker which has a very strong relationship with dietary intakes. Okay, so we'll look at biomarkers after this. And then biomarkers also provide independent assessment of intake of foods or nutrient for mean energy intake, which is often acceptable in an acceptable range. So we have biomarkers for calorie intake, certain protein intake. We don't have for carbohydrate, we have for fat, and certain macro and micronutrients. Okay. Whereas measuring relative validity is when we use subjects of same gender, socioeconomic status, race, age, geographic region, and also subjects who are representative of the study population. So we self-select the subjects so that the respondents may be more accurate, and but then those who are self-selected might have healthier diet or more health conscious compared to the overall population. Disease of the subjects might influence the food intake. If you have certain type of disease, you might affect the appetite and also food intake. So there are some methods that we can do where we can have case and controls when during our relative validity experiments. The study objectives and time frame for relative validity is depends on the 4 levels of objective that we will see after this, and the reference method must measure the similar parameter over same time of frame. Whereas in the sequence and spacing during relative validity measurement, the test method must be first used to mimic the situation in the proposed subject. So you must do the test method first, then only the reference method later on. So sometimes the test method conducted before and also after the reference method. So you can do the test method before the reference method, and then the second time you do the reference method, and then you repeat back the third test method at the end of the study. So you have 3 time point for relative validity. This is to avoid training and also sequencing of food intake. Okay, and finally, time interval between the two methods. If it is too long, we have discussed about this before this. If it's too long, if the seasonal influences might kick in. So the time interval should be appropriate, 4 to 8 weeks for relative validity. So these are the selection of methodology to measure nutrient intakes to meet 4 possible levels of objective. So our objectives can be arranged into 4 levels. Level 1 is when you want to determine the mean nutrient intake of a group. So this is usually done in a small research project. So you want to know the mean nutrient intake of certain group. So the preferred approach method is a single 24-hour recall or single weight or estimated food record with large number of subjects. So you might have 1,000 subjects, 2,000 subjects, okay? But then you can do only single 24-hour record or single weight or estimated food record. You need a large number of subjects because you're only doing a single recall, and this will be adequate representation of all days of the week. So you cannot do all the interviews on Monday. So some people might have to do the interview on Monday, some on Tuesday, Wednesday, Thursday, and so on. For level 2, we calculate the population percentage at risk. So when doing this, the preferred approach is to replicate observation on each individual or a subsample using 24-hour direct recall or weight or estimated food records. So we'll do a replicate of observation, means that we use 24-hour direct recall and then we use a weight food record. 2 types of measurement on the same individuals. Level 3 is ranking individuals by food or nutrient intake. For this, we use multiple replicates at 24-hour direct records, 3 days, 7 days, okay, of food records, or a semi-quantitative FFQ. So when you do a semi-quantitative FFQ, you don't have to have a multiple replicates, but it's enough to do it once because FFQ is asking about frequency of intake. And level 4 is determining usual intakes of nutrients of individuals. We are no longer interested on the group, we are interested on the individual itself. So when we are measuring an individual level, we need larger number of recalls or records for each individual. So instead of only 3 or 7, you might need 14 recalls, 21 recalls, and so on. And alternatively, you can use a semi-quantitative FFQ or a diet history to avoid doing a large number of recalls with that person. So this is the yeah.
Sorry, Jess here. In the previous slides, right? May I know the example of ranking the individuals, the level 3 one? Like
Okay.
What does the ranking individuals mean?
Okay, ranking individuals by food and nutrient intake means we wanted to know which person is at a higher intake and which person at a lower intake of food and nutrient intake. So we want to arrange them from the first quartile until the 4th quartile. So if you are familiar with quartiles, where we divide the whole population into 4 groups, and then we can say that those in quartile number 4 is those who consume the highest level of intake, whereas those in the lowest quartile, quartile 1, they are at the lower range of intake, so therefore they are at the lower ranking.
Oh, so what's the difference between level 2 and 3? So 2 is population, so it's like overall.
Yes, Level 2 is to identify those who are at risk. So overall, how many percentage of the population is at risk? But then level 3 is to identify subject A is in which ranking, which quartile. Subject B is in which quartile.
Okay. Thank you, doctor.
Come. So these are the appropriate combination of tests and reference dietary methods in relative validity. So you can see on the left hand side is the test method and the right hand side is the reference method. So if your test method is single 24-hour diet recall, the pair for reference method is single 1 day weight food record. So normally the reference method will be more accurate method in measuring food intake. So we know that weight food record is somewhat gold standard in measuring food intake because there is no errors in estimating food or portion size because the weight are already measured for you. So when the test method is multiple 24-hour diet recall, again the reference method is multiple 1 day weight food record. So you can have 7 days weight food record for 1 whole day. Okay. So if your test method is FFQ over 1 year, your reference method will be 4 sets of 7-day weight food record. Why 4 sets? Because you divide the year into 3 months interval, and then there's space to account for seasonal variation. So the reference method will be 4 sets of 7-day weight food record. So overall you have 7 times 4 is 28 days weight food record over a year, and that year is divided into 3 months interval. So you have 4 sections, and you also must give some space to seasonal variation. If you are interested to test diet history over a month as your test method, so your reference method is multiple 1 day weight food record spaced evenly over 1 month. So so the number of days actually depend on the nutrient that we'll see after this. So if you are doing a diet history over a month, so all your weight food record should be spaced evenly in a month. Different from before this, because your FFQ is over 1 year, therefore data from the whole year. When your diet history is only over 1 month, you only need data spaced evenly over 1 month. You can have 14 days weight food record, but it's spaced evenly in a month. Okay. But when deciding how many days is needed, you should see the number of days required to estimate true average intake for groups of individuals with given statistical confidence. So here we can see that if you are interested to measure energy intake, so 3 days is enough for both male and female. So that's what we are doing now. Protein intake, you need more days, 4 days for males and females. Fat intake, you'll need even more days, 6 days. Carbohydrate, 5 days. Fiber, 9 days. If you want to measure vitamin A, you need up to 39 to 44 days of measures if you really want to assess vitamin A, because the variation, daily variation of vitamin A is quite high. Similar to vitamin C, 19 days to 33 days. So this is actually from a research. If you have the Lee and Neiman textbook, you can see this table. Is from a research in US where they did research for males and females, and these are the estimation. So we can use this as a guide when we are planning absolute relative validity research on our own. So normally we'll need at least we need energy, protein, fat, carbohydrate, right? So if you can see here, we need at least 6 days. So we can do a 7-day diet recall as a reference method, and our DHQ can be over 1 month. We can also do FFQ over 1 month. Okay, we can the reference time. The reference time is depend to us to be set, whether it's over 1 month, over 1 week, or over a year. Okay. So if we are doing estimate true average intake for an individual, because this is for a group, yeah, for an individual, the number of replicates needed will be higher compared to this, because for groups will be lower number of days. For individuals, we'll need a bigger number to estimate to be the reference method. So let's look at the factors influencing relative validity of FFQ. So there are several factors that might affect our relative validity of an FFQ. So we are using as an example FFQ here because most of the validity studies conducted for FFQ, whether it's validity or reproducibility, it is for an FFQ, because we always develop new FFQs for new populations. So the number of subjects, there is no effect on correlation coefficient in relative validity of FFQ. In terms of method of estimating portion sizes, a higher correlation with individuals' own portion size versus average portion size set for that population. And then if you use a sex-specific portion size, means that for female you have different types of portion size, and male you have different types of portion size. The validity is higher when you compare to a single average for both gender. The method of administration, there is a higher correlation when using interview, which is not self-administered, as interviewer can directly check responses. If you ask the respondents to answer themselves, the relative validity might be lower because they might simply tick and circle whatever they want without the interviewer being able to check their responses. In terms of telephone versus face-to-face interviewing in USA, there is no difference, but we do not have data for Malaysia yet. Okay, so the length of reference period might affect the relative validity, where recall over past month is better than over last year. So if you do a reference period over past month, the relative validity will be higher compared to when you do a reference period over last year. So let's talk about biomarkers. So we have mentioned about biomarkers earlier. So biomarkers is also used to test for validity, because when you have different types of methods which still doesn't give you a good result for validity, you have to use a biomarker. So biomarker is any biochemical index in an easily accessible sample, example like blood, urine, hair, nail, feces, that gives a predictive response to a given dietary component. So biomarker, although it's a biochemical index, it is not free from error, but it has the potential to be more valid and precise compared to other types of dietary assessment. So your blood cannot lie to you. This biomarker should be an objective biochemical measure that reflects the dietary intake, and often it's invasive because to draw blood and urine is not that invasive. It's not to draw blood and other things, urine, nail, hair, feces, is invasive. Sometimes we need tissue samples, which is invasive. The process is expensive and also time consuming. So the person might need to be fasting. We have to prep them, ask them to come to the clinic, plan when it's the time to draw the blood samples and so on. Biomarkers can only validate one nutrient at a time. Okay, so we cannot have a bottle of blood and then a tube of blood and then you want to validate all nutrients. No, you can only validate one nutrient at a time. So these are the examples of biomarkers being used frequently in research. For protein intake, we use 24-hour urinary nitrogen excretion as a biomarker. For iodine intake, we use urinary iodine using spot urine samples with at least 10% repeat to account for within percent variation. Because 90% of the iodine that we consume is excreted in the urine. Okay. For sodium intake, we also can do 24-hour urinary sodium. For potassium intake, again, urinary potassium, because around 77% of potassium is excreted in the urine. Carotenoids, vitamin C, vitamin E, these are antioxidant vitamins. We usually measure in plasma or serum sample. For fatty acids, we can measure in plasma and serum, but the best is to measure in adipose tissue fatty acids. So it is quite invasive to get an adipose tissue from a person's body for the measurements of fatty acids. So we have come to the final slide here. These are the recommended design for validating FFQ. So we have talked a lot about validity and reproducibility. Sorry. So validity and reproducibility, like I've mentioned before, is normally done for FFQ. So this is a process, the design that we usually do for validating FFQ. We usually include multiple 24-hour records because 24-hour weight food record is quite difficult to be conducted. So we resort to 24-hour records, but it must be multiple 24-hour record. And FFQ, and also we include a biomarker when validating FFQ. The space between 24-hour records over the same period of the FFQ. If the FFQ is measuring over the past 1 month, the 24-hour direct record should be assessing over the past 1 month as well. If the FFQ is for the past 1 year, the 24-hour direct record must be measuring throughout the year as well. The space biomarker equally over the same time period for 24-hour direct record. Okay, but there is some caution. We do not take biomarker on the same day as the record day. Preferably should be placed at least 2 days apart from the 24-hour direct record. Okay, and then this is the quite important point where we should use several statistical tests to assess validity. Normally we have 3 to 4 types of tests to do to assess validity. Can anybody name the tests that we usually use for validating FFQ, if you are aware of the tests besides correlation? Anybody? How do you assess validity? What test is suitable to test validity? Let's start with this most simple test. So you have 2 types of method, 2 or 3 types of method. Let's take 2 types of method, but you measure on the person, on the same person twice. So what type of test is that? Anybody want to try? Come again? Independent test, is it?
Yeah.
It actually should be a paired t-test because you measure the same person. So it should be a paired t-test. Okay, so a good try. So besides paired t-test, you have correlation. You can do Spearman or Pearson correlation depending on the normality of data. You can also do Bland-Altman statistics if anybody have heard that before. You can do a cross-tabulation chi-square test to see whether the ranking for FFQ and 24-hour diet recall is similar for a person. So you can do a chi-square. We can also do intra-class correlation. These are all advanced tests that you can do. Okay. So the normal one will be correlation and paired t-test and Bland-Altman. Okay. So you must have several statistical tests. You cannot have only one, and then you cannot say based on one test it's valid. Okay. You must have several tests. You must also ensure that your dietary assessment method has been validated appropriately before being used. Means that your reference method should be validated appropriately before you use to be a reference method to validate an FFQ. So you should also remember that you cannot assume that a method has been validated in one setting is transportable to another context. So let's say you have an FFQ which is validated in United States. You cannot use them for Malaysian population before doing revalidation because that population is quite different from our population here. So you should also always give details in your methods of the setting and food and nutrients for which the method has been validated when you report an FFQ. Okay, so whenever you talk about FFQ, the first question before you use an FFQ, the first question that people will ask is about the validity of the FFQ. Okay, so there is no validity test for 24-hour diet recall, weight food record, and so on because that's just measuring whatever is there, but it's different for FFQ, diet history questionnaire, any other questionnaire. You should validate it first. I'm sure you have learned this in your biostatistics class with Dr. Mahathir, if I'm not mistaken, right? Okay, you have learned this, right? About validity, reliability.
Yes,
Not
yes.
yet?
Dr. Mahathir.
Dah belajar? Not yet?
Dah.
Okay. You have learned, eh? Okay, good. So that's all for issues in dietary measurements. Any questions so far? This is a very straightforward topic. And this is the end of the whole dietary assessment topic. So you have learned about types of dietary assessment. You have learned on the techniques. Now you have learned about the issues in dietary assessment. You also have learned on RNI, and tomorrow we'll have a presentation from you. So I'm hoping to hear a good presentation from all of you tomorrow.